Tonight, I want to share with you some research findings relating workplace settings and job types to health disparities. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Recent emphasis on social determinants of health additionally reveals that health disparities results from inequalities in where you live, where you work, and where you play. This paper explores how where you work, the type of job you hold, impacts your access to health insurance and then indirectly influences your health. Insights about the relationship are critical in Memphis, particularly because Memphis has some of the worst health disparities in the nation. If we're talking about heart disease, we're talking about stroke, we're talking about diabetes, we're talking about HIV, Memphis stands out in the nation. Some of my current work is looking at racial disparities in breast cancer mortality. In 2012, Memphis was noted to have the highest racial gap in breast cancer mortality of the 50 largest cities in the country. Here's a picture of the relationship I want to share with you on tonight. We're going to look at job choice, or where a person ends up working, and how it's related to health insurance coverage, and then related to health. There are two sectors in which a person can work. They can work in the traditional sector, or they can work in the non-traditional sector. The traditional sector is probably where most of the people in this room are currently working. The non-traditional sector includes contingent workers, and these are workers whose jobs are temporary or are not expected to last for long for some reasons that are not related to their personal situation. Non-traditional workers also work in alternative work environments, and these are workers who are paid by contract firms, temporary help agencies. They are day workers, day laborers, on-call workers, independent contractors. Depending upon where a worker ends up, the traditional or non-traditional sector, that will influence their health insurance coverage. Is it going to be employer-based? Will they have public insurance or have a private option, or will they be uninsured? Depending on their health insurance coverage, that will impact whether they have access to or affordability of health care and their health outcomes. So this is the path we're going to take today. There are 21 million workers in the alternative and contingent work sectors, that non-traditional sector. 21 million workers. That represents about 14% of the workforce in the United States. Among workers in the alternative work environment, independent contractors are the largest percentage of workers. You'll see on this chart that they are 6.9% of the labor force. These data come from the current population survey, which is basically the national database that is accessible to everyone to talk about where workers are employed. It's the gold standard. While CPS data suggests that the non-standard employment sector is stable and slightly decreasing, as you can see with the numbers that are on the table, the data tend to underrepresent two employment trends. First, current population survey data only capture information about your primary job. They do not capture information about your secondary job. As we know, many workers have to seek an opportunity to stretch their income when their primary job is associated with wages insufficient to provide a living wage. If we seek information from Upwork, they suggest that in contrast to 21 million people working in this alternative and contingent work sector, there really are 57 million people. A growing number of workers are fleeing to what we call the gig market in order to survive. The growth of numbers of workers who are working for firms like Uber and Lyft also supports the supposition of a growing number of workers in the non-standard employment sector. So what you're looking at here is probably an underestimation of what really occurs in the market. This slide I want you to also recognize as being important, because hidden in the numbers for trends in non-standard employment is a growing racial divide in the employment sector. There are differences between white, Black, and Hispanic workers in how they are represented over time in the contingent and alternate work arrangement sectors. Between 2005 and 2017, there was a decline in white workers who were employed in the contingent sector and the alternate work sectors. However, as you'll notice in this chart, Black workers were an increasing percentage in the contingent work sector from 12% in between 2005 and 2017, and for Hispanic workers, there was an increase for them of 10%. In the alternative work sector, there was an increase for Black workers, 41%, and an increase for Hispanic workers of 46%. And let me just reiterate what I'm trying to emphasize. The numbers on the previous chart just say, this is a small sector relative to the whole market. We're talking about maybe 14% of the labor market. But what else is going on is there is a transition in the racial composition of the workers who are in the different sectors, with a very large change in the racial and ethnic composition, with more Black and Hispanic workers moving into those alternative sectors of work. These trends suggest growing racial divide in the employment sector due to racial employment and wage differentials in the traditional labor market, driving more minority workers than white workers into the non-traditional sector. Now, this is why it matters. There's a relationship between health insurance and work arrangements. The primary reason that employers develop non-standard workforce agreements is to save money. In manufacturing, the use of workers from temporary help agencies increased from 30% in 2005 to almost 40% in 2017. Sometimes non-standard workers are used as the alternative to raising wages for workers in standard work arrangements. Such strategies may be used to avoid paying overtime wages or of time and a half and reduce expenditures on fringe benefits. This is a so what. And then when we look at health insurance coverage varies by whether one is employed in the traditional sector versus in the non-standard sector. Coverage also varies by race and ethnicity. In some earlier work that we did when we were looking at data from 1995 to 2001, we tracked health insurance coverage for traditional workers and non-standard job market workers, they're reported in the last two bullets. You'll see that no one has 100% likelihood of having health insurance coverage, regardless of the sector in which you work. However, if during that earlier time period of 1995 to 2001, if there was employment in the traditional job market, white workers were 70% covered, 71% covered. Black workers, 72% were covered, and Hispanic workers, 58% were covered in the traditional market. So you have ethnic racial variation in whether health insurance coverage exists, even in the standard traditional market. If you look at the non-standard market, you still maintain the racial ethnic differences, but you also notice in those last figures that health insurance coverage is less than, well, twice that, health insurance coverage is almost twice as likely in the traditional sector than in the non-standard sector. So white workers, 32% had coverage in the non-standard sector, 26% of blacks, and 21% of Hispanics. So it makes a difference where you work. That non-standard market greatly impacts health insurance coverage. By 2005, 56% of workers in traditional jobs had health insurance coverage. So by 2005, we were entering into that recession. And employers were saying, oh, health insurance is really expensive, and we're dropping health insurance coverage. It impacted the traditional market, with 56% of workers in the traditional market having health insurance coverage. And in the non-traditional market, only 18% of workers had health insurance coverage. Importantly, by 2017, there was an increase in health insurance coverage, with most of the increase in coverage occurring in the non-standard worker market. 53% of workers in traditional jobs had health insurance coverage under their employer's plan, and 25% of the contingent workers had health insurance coverage. But look, at the next bullet, there's variation in that non-traditional sector. 28% of persons who were on call had insurance. 13% of those who were working for temporary health agencies had health insurance coverage, and 41% of workers who were contract workers had health insurance coverage. Health insurance and health disparities, the last link on that chart that you saw on the second slide. Health insurance and disparities. The Institute of Medicine reported that uninsured persons receive less preventive screenings, they're less likely to receive healthcare services in a timely manner, they receive substandard care, and have a higher risk of dying prematurely, including higher rates of death in the hospital. Health insurance also influences racial and ethnic health disparities in use of preventive and screening services, and also cardiovascular disease services. Economically vulnerable populations have greater improvements in health due to increases in health insurance. So if you take a person who is economically vulnerable and you give them health insurance coverage, their health will change, and it will change by more than the change that occurs when you take a person who is not economically vulnerable and you give them the same health insurance policy. Since health insurance status is so closely linked to health status and health disparities, and since job sector has critical implications for health insurance coverage, workplace settings and job settings are to some extent de facto determinants of racial and ethnic disparities in health. Memphis and non-traditional sector. It's very difficult to get data on Memphis and the types of jobs that people have in Memphis. So the closest I could get was to get some data for the East South Central region, where Memphis is the largest city in that region. The East South Central region has a similar distribution of workers as that shown in the previous charts for the national market. The East South Central region has a slightly lower likelihood of independent contractors. That's the group that has a greater likelihood of having insurance, and a slightly higher likelihood of workers employed by temporary help, employed as temporary help workers. That's the group that's least likely to have health insurance. Herein lies the health insurance concerns for residents of Memphis. National data indicate that workers employed by temporary help agencies were the least likely to have employer-provided health insurance. Only 13% had coverage in 2017, and only 8% had coverage in 2005. And workers in the East South Central region were more likely than workers in the nation to fall in this category. Indeed, the coverage rates for these workers is extremely low, suggesting severe limitations in access to healthcare services for those employed by temporary help agencies. These workers are also most likely to be Black or Hispanic. We were asked to think about the policy implications of our work. And the first thing that came to mind to me was, what's the connection between all of this and minimum wages? Minimum wages and employment in the alternative work sector. Well, rising minimum wages would make employment in the alternative work sector less needed and or less desirable, because that's the sector that people are going to because they're not getting a living wage. And so they have to seek other ways of increasing their income and resources. Thus, higher burdens of long-term health risks faced by Black and Hispanic workers would decline if we had rising minimum wages. Doubling the minimum wage is a popular policy recommendation. It's basically justified by arguments that wages need to be high enough so that workers, in effect, receive a living wage, a wage that allows their families to move out of poverty. Opponents of changes in the minimum wage focus on how additional wage costs would increase the cost of doing business and drive down profits. However, both proponents and opponents of a rising minimum wage often fail to consider something that's really important, and that is that when a worker has access to health insurance and a worker has a higher minimum wage, then they can take those resources and invest in themselves, and they can become more healthy, and they can become more productive, and then the employer makes more money. Second bullet, health insurance and the workplace. Currently, the workplace setting has a significant influence on insurance coverage as well as one's quality of life and life expectancy. It is not clear why such a connection between the workplace and life expectancy is necessary or desirable. Now I'm going back to that first chart you saw that was linking job and health insurance and health. I'm questioning, is it necessary to have that first link between your job and your health insurance? Can we dismiss that link? What would that take? Why don't we separate the connection by giving serious consideration to universal health insurance coverage? Why is it whether it's an extension of the Affordable Care Act that fills gaps in coverage, or an overhaul of the health insurance system that is replaced by some variation of Medicare for all, it is not clear whether the additional costs, and this is the argument that's made, whether the additional cost of financing these new health insurance systems outweigh the benefits. What's the cost? What's the cost? Well, what are the benefits? This is because most calculations of the cost of a new health insurance system compares health expenditures under the new system with health expenditures under the current system. And there's a question of whether we can afford the additional cost. No adjustments are made in these cost calculations for the benefits of the new system, such as reductions in premature deaths. What's the value of that? A reconsideration of our healthcare system is critical for persons who must work in alternative employment arrangements in order to secure a living income for their families.